CRNA Financial Planning is a sponsor of Beyond the Mask podcast. Investment advice offered through Private Advisor Group. Nothing in this podcast should be construed as investment advice. Plus, did you know listening to our podcast can earn you Class B credits? For details on how to submit, visit the CE credit section at beyondthemaskpodcast.com. Welcome to the Beyond the Mask podcast. This is the Anesthesia Alchemy edition. Join hosts Gary Bridges and Lynn Maxey as they deep dive into today's most important clinical conversations.
Welcome back, everyone, to Anesthesia Alchemy, Lynn and Gary Unplugged. Unfortunately, today, Lynn will not be joining me and we don't have a visitor, so I thought it would be a great opportunity, to talk about a topic that every anesthesia provider knows matters, and that's every patient will definitely remember and every recovery room area deals with constantly, and that is postoperative nausea and vomiting, or PONV. And specifically, we're going to walk through the 5th consensus guidelines for management of postoperative nausea and vomiting, the 2025 update. It's a popular document. Not sure if everybody has opened it and looked at it again, but there are some changes, and it's important to update all of our anesthesia colleagues, but especially for us nurse anesthetists, because much of the postoperative nausea and vomiting prevention happens in the decisions we make every day. What anesthetic we choose. Are we using volatile agents versus Ativa? Are we planning opioid-sparing anesthesia? And are we hydrating our patients adequately? Are we providing one antiemetic, or are we really building a thoughtful prophylaxis strategy to abate postoperative nausea and vomiting? And when prophylaxis fails, are we rescuing that patient correctly? Those are the CRNA decisions made every day with every patient that we care for. Those are perioperative decisions that we see are impacting the recovery room nurses as well as the patients. And those are patient experience decisions that we make that either make it really great for the patient, for their experience, or not so great. Well, let's be honest. Patients may not remember every detail of their anesthetic, but if you talk to patients, they absolutely remember if they woke up miserable, nauseated, retching, dizzy, dehydrated, and unable to go home in a comfortable fashion at discharge. For many patients, PONV is not a minor side effect. It is the outcome that many do fear most. I know there was a study way back in the early 2000s, perhaps even late 1990s, that was to give a patient $100, and they were allowed to either keep the $100 or spend it anywhere on their anesthetic journey or perioperative journey. With overwhelming response, the majority of people would spend all that money to not have postoperative nausea and vomiting. So it's a real issue. And the 5th consensus guidelines make it clear that postoperative nausea and vomiting prevention needs to be approached in a more deliberate, multimodal, and system-level way than ever before, because we've got so many things available to us. So in this episode, we're going to cover things like why the 5th guidelines actually matter to us, what has changed compared to the 4th consensus guidelines many years ago, and how adults and pediatric recommendations have now evolved into a more meaningful content for our practice, and what this means in actual CRNA practices. And at the end, I'll give you a few key clinical takeaways to use in the OR, GI suites, ambulatory centers, or PACU handoffs, wherever it is that you're interfacing with. So let's start with why postoperative nausea and vomiting still deserves so much attention. And one of the first things to say is that PONV is still incredibly common, unfortunately. The guidelines reiterate that it remains a frequent adverse event after surgery and anesthesia, and optimal management requires a multidisciplinary approach through evidence-based care and a level of institutional support. Because now you got nurses and you got medical assistants, etc. If they're out in the recovery room, heaven forbid they have that in the operating room after extubation. Not common, but it does happen. when patients go home, they may get through the perioperative process and are ready for discharge. And then once they get on the road or once they get home, now they have this terrible experience of PONV. So words matter. It's not just give some ondansetron and hope for the best. This is a perioperative quality issue, and certainly many of us are being graded on that as far as quality markers. This is also discharge efficiency issues, right? When people go home, as I've mentioned, you don't want them succumbing to postoperative nausea and vomiting. It's also an ambulatory surgery issue because there's an economic impact with that, as well as a patient satisfaction. And in some populations, it's a safety issue. Somebody having terrible postoperative nausea and vomiting, and I can tell you in one area would be patients with plastic surgery. It's a problem. And if they're larger patients, that can actually contribute to things like wound stress, bleeding risk, aspiration concerns, dehydration, electrolyte disturbances, delayed recovery room or PACU discharge, unanticipated admissions, and serious distress for the patient and the family. I can think CRNAs understand this really well. We all know that because we live at the intersection of the physiology and the workflow that we do in the operating room every single day. We see when the patient's otherwise ready to leave, but nausea is the thing that holds everything up. And it's frustrating for the patient, it's frustrating for the recovery room nurses, and certainly it's frustrating for us to witness because it's sort of a ding in our pride, if you will. When we see these patients that are well pain controlled, vital signs are stable, yet the patient's pale, sweating, gagging, can't tolerate fluids, it's very disturbing. We even see when, perfect anesthetic from our perspective is judged by the patient as a bad experience because they spent the first 2 postoperative days nauseated or vomiting. And it's so significant that these guidelines are really not abstract anymore. It's very practical recommendations based on these consensus guidelines. So the panel behind these recommendations reviewed all of the latest updated literature. And I can tell you, when I was chief nurse anesthetist, I delegated this, or I was given the opportunity or privilege to find a CRNA and place them on this panel. And I've certainly have done that over the course of years. But some of the things that the consensus guideline looks at is what are some of the risk factors that we got to consider. Not a lot of that has changed yet. Risk reduction interventions, single and combination antiemetics, postoperative or post-discharge nausea and vomiting, pediatric nausea and vomiting, pharmacoeconomics, and the integration into enhanced recovery pathways. So this is not a narrow medication update, and so we will fill the entire 50 minutes on this. This is a broad rethink of how we approach postoperative nausea and vomiting, not only in the prevention, but also the treatment. So let's look at the big picture change from the 4th to the 5th consensus guidelines. And if I had to summarize the biggest theme in the 5th consensus guidelines in one sentence, it would be this. The field is moving towards broader multimodal prophylaxis, not narrower minimalist prophylaxis. Let me say that again. The field, anesthesia delivery, or PONV prophylaxis, is moving toward broader multimodal prophylaxis, not narrower minimalist prophylaxis. So that's one of the clearest changes in tone, if you will, that I got from the guidelines after leafing through them in some significant detail. Now, the guidelines do still support risk assessment tools. They still validate risk stratification management, but they also acknowledge ongoing discussions around adopting sort of a more liberal approach to prophylaxis because of undetected risk factors that we're completely unaware of, inconsistent adherence to risk-based algorithms, and the ambiguity in interpreting individual risk factors. That's really huge. Because historically, many of us were taught something like low risk gets little or nothing as far as prophylaxis. Moderate risk gets 1 or 2 interventions, and high risk gets more aggressive prophylaxis. And what the 5th consensus guidelines are now saying is, yes, risk scores still matter, but in real world practice, many patients are underprotected. And we now have enough safety data on common antiemetics that a general multimodal approach is increasingly reasonable and prudent to incorporate in our practice. That's one of the biggest practical shifts that we've seen veer off from the older frameworks, if you will. Now, another major change is that the guideline places stronger emphasis on the following things: post-discharge nausea and vomiting, evidence-based combination therapy rather than just class variety for its own sake, risk mitigation strategies in addition to the antiemetics that we're ordering and administering, pediatric specific algorithms, this is a big one, and implementation within enhanced recovery pathways and institutional systems. Really, really important. So compared to the fourth consensus guidelines, the fifth consensus guidelines feel more integrated. When you go through and read these, they're a little bit more multimodal, if you will, more implementation focused, and making us more aware that postoperative nausea and vomiting care actually extends beyond the PACU. So with that in mind, let's go to adult risk assessment. Still essential, just not sufficient by itself. Now, the guidelines continue to support validated PONV risk tools, especially the APFL simplified score. Patients with a 0 risk factor are low risk. 1 to 2 risk factors are medium risk, and 3 or more are still high risk. And so what are those risk factors? Well, according to the APFL or the classic APFL risk factor, remain familiar, right? Like female sex, non-smokers, history of PONV or motion sickness, perioperative or postoperative opioid use. Now, the guidelines, there's a figure in the guidelines that actually show sort of the risk factors corresponding roughly to the percentages of postoperative nausea and vomiting. So if you have 0 risk factors, your PONV risk is about 10%. If you have 2 risk factors, it's 20%. PONV risk. If you have 3 risk factors, PONV risk is 40%. If you have 4 or more, you can have between a 60 to 80% risk factor of having or succumbing to postoperative nausea and vomiting. Those numbers are still useful today. They help us estimate risk quickly, obviously, in our mind. They also help communicating rationale to colleagues that we work with. For example, if you're handing off to someone. They also help standardize sort of the decision-making process. So, these guidelines, the newer ones, also describe novel and emerging risk factors that are reported since the prior consensus. And this is a really nice reminder that biology is always more complicated than a 4-factor score, risk score, if you will. And among sort of the newer reported associations is lower preoperative physical fitness, such as ASA3s, are associated with one retrospective study that there is a decreased likelihood of postoperative nausea and vomiting. Interesting. Higher hemoglobins and hematocrits were associated with less postoperative nausea and vomiting. Elevated neutrophil to lymphocyte and platelet to lymphocyte ratios were associated with higher incidence of postoperative nausea and vomiting. Avoiding intraoperative hypotension and using goal-directed fluid or hemodynamic management potentially reduces postoperative nausea and vomiting. Overweight or obesity has a lower incidence of postoperative nausea and vomiting than patients with lower BMI in one propensity matched analysis study, which is really interesting. Now, do these findings replace the APFL risk score? No. And the guidelines actually explicitly note that adding more and more risk factors to prediction models is unlikely to dramatically improve the model performance at a population level. So identifying a whole bunch more batteries of risk factors is not necessarily going to change sort of how we stratify and how we administer. And that's a really important point. We don't need to create a 27-factor scoring system that no one could use in practice and it just becomes unmanageable. But as clinicians, we really should be aware that individual patient risk is shaped by more than just 4 classic variables, right? The guidelines also call for us to pay a little bit closer attention to specific surgical populations that do, in fact, actually have higher risk. And that's bariatric surgery, laparoscopic cholecystectomies, urologic procedures, knee arthroscopy, breast surgery, gynecologic surgery, and obstetrical surgery. All of those carry higher risk of postoperative nausea and vomiting. And that tracks with what many of us already actually know or see clinically. So, the practical message here is use the score, but don't become enslaved to the score. Use some critical judgment. And, these risk tools don't replace good, prudent judgment. Okay, let's go into something called PDNV, post-discharge nausea and vomiting. And that is starting to get more attention in the consensus guidelines. It's an area where the fifth guidelines feel especially useful, I think, when you go through it. The document also emphasizes that PDNV is a major issue because once the patient leaves the facility, they no longer have immediate access to fast onset IV antiemetics or direct clinical support. And that's obvious, but it's very practical, certainly in ambulatory anesthesia facilities. It's a reality. The guidelines include a simplified PDNV score with 5 risk factors. Again, this is female gender, age under 50, history of PONV, opioid use in the PACU, and nausea in the PACU. Risks rise from roughly 10% with 0 factors to 80% with 5 factors that we just finished listing. Think about how useful that is. Now, a patient may look okay enough for discharge, but if they were nauseated in the PACU, get opioids there, and already had baseline risk factors, whether it's age and gender, etc., you should be thinking ahead. What happens to this patient in the car ride home? What happens tonight when they're at home trying to go to bed? What happens when the IV is out and they're trying to take oral pain medications? That is a major mindset shift. PONV management cannot end at the PACU doors, right? We all know that. And the guidelines highlight longer acting options for PDNV prevention. One of those is polanzitron, which significantly reduces PDNV and rescue antiemetic use in the postoperative days 1 and 2. Really important one. That drug's been around for over 20 years. Just a lot of people maybe have not used it. Olanzapine reduces PDNV, but at the cost of more sedation. So this is a little bit of a sedative, if you will. Patients do get sleepy from it. And orally disintegrating formulations, such as ramacitron or ODT in some regions, may help after discharge. And there's also dissolvable ondansetron. So from a CRNA perspective, especially in ambulatory settings, one of the smarter questions to ask now is not just, will the patient have PONV and PACU? It is the patient likely to struggle with nausea and vomiting after discharge? And am I choosing the correct prophylaxis accordingly? That's a more sort of complete way to think about it based on these new 5th consensus guidelines. Let's look at social determinants, equity, and special populations. One of the underappreciated strengths, I think, of these guidelines, the 5th consensus guidelines, is that they discuss disparities in vulnerable populations. Now, the guidelines note that social determinants such as sex, gender, race, socioeconomic status may influence access, treatment, and outcomes. And these factors are often underrepresented in randomized trials related to PONV management. So it also notes that evidence suggesting that patients of lower socioeconomic status may be less likely to receive antiemetics after correcting for some confounding variables in their care. Now that's worth sitting there for a second and pondering a little bit, because standardized protocol-based care can actually improve equity if we implement it in our practices. When prophylaxis is based only on habit or subjective impressions, some patients will inevitably be undertreated. That is a given. Now, the guideline also discusses transgender patients as potentially vulnerable population and notes increases in PONV risks observed in transgender patients undergoing facial gender reaffirming surgery compared to cisgender patients undergoing oral and maxillofacial procedures. And it notes that gravid patients undergoing non-obstetric surgery under general anesthesia had comparable postoperative nausea and vomiting incidents as non-gravid patients, yet fewer prophylactic anemetics were actually prescribed or given. Again, the lesson here is not just memorize these subgroups, it's the standardization and evidence-based approaches to care that actually matter. So when a system doesn't have a consistent prophylactic approach, patients at equal or higher risk may receive less protection. And that's on us. That's a clinical issue, and I would even submit it's also a system issue. Now, let's get into risk reduction, the anesthetic plan itself, if you will, as an antiemetic strategy. And this is, maybe one of the most CRNA relevant topics out of these whole number of pages of guidelines, because before we ever give a drug for nausea prevention, we have already made multiple decisions that actually influence whether the patient becomes nauseated or not. So one of those things would be propofol TIVAs. The guidelines reaffirm that actual propofol total intravenous anesthetic is a major risk reduction strategy that CRNAs can employ. Propofol TIVAs alone have comparable PONV risk to volatile anesthetics plus 5-HT3 antagonist or droperidol. And both propofol TIVA and subhypnotic propofol infusions can be effective in combination with other antiemetics. That's a powerful statement, folks. In other words, anesthetic technique is not just a background choice, it's one of your strongest antiemetic decisions. For high-risk patients, TIVAs deserve serious consideration. I can tell you in my practice, whether I'm using propofol as the main agent or I will run it in the background at 5 to 10 mics per kilo per minute as one of those, not just multimodal strategies, which we'll talk about next, but in an effort to mitigate or minimize the risk of postoperative nausea and vomiting. So let's talk about multimodal systemic analgesia. The guidelines also identify multiple analgesic strategies to reduce PONV risks. And, we all know this now from opioid-sparing techniques, acetamin, IV acetaminophen, intraoperative ketamine, esmolol infusions, lidocaine infusions in laparoscopic abdominal procedures, NSAIDs and COX-2 inhibitors, and low-dose gabapentinoids in some analyses or some studies have demonstrated. Now, opioid-free anesthesia reduces PONV compared to opioid-based, obviously, though the comparisons with opioid-sparing multimodal strategies is less clear. And this is where it sort of starts to get cloudy. While, our intent is to give opioid-free anesthesia, but there are those patients that we're not sure of who have breakthrough, and when they have breakthrough, we do have to sometimes rescue with an opioid. Fine. What is that opioid that we should be choosing? And everybody has their own rationale. I tend to defer to hydromorphone or Dilaudid just because it's a little bit longer acting. It just doesn't seem to have the risk associated with it comparative to the other strong opioids for PONV. Now, every opioid you avoid does help in two directions. Obviously, a better nausea profile and an often better recovery quality overall. And we've all seen this, those of us that are doing opioid-sparing techniques. Now, something else is regional and neuroaxial techniques. The guidelines do note that epidural analgesia does reduce postoperative nausea and vomiting risk, although opioid-containing epidural mixtures are still associated with a higher risk than plain local anesthetic preparations. It also supports techniques such as tap blocks, QL blocks, continuous wound infiltration. And again, less systemic opioid generally means less nausea burden in these patients. Now, I think every one of us learned in school that nitrous oxide causes nausea and vomiting. And so that still sits in the guidelines, avoiding nitrous oxide in certain emetogenic exposures. Now, nitrous oxide as a maintenance anesthetic increases postoperative risk. That study, and I know there's been, some studies that have tried to repeat it, but that was done, I believe it was back in the 1940s. So it's old information. Some providers will tell you that nitrous doesn't contribute to postoperative nausea and vomiting. It's debatable. In the consensus guideline, it is tend to try to avoid it as best we can. Sugammadex, another practical point here. Sugammadex reduces the incidence and severity of postoperative nausea and vomiting, particularly in the PACU. This is an important point because reversal choice is often not framed as a part of a PONV plan, but now that Sugammadex is now off patent, maybe this is something that we should actually be incorporating in all of our practice. Now let's get into fluid management, hemodynamics. Supplemental crystalloids do reduce the risk of early and late postoperative nausea and vomiting. Colloids may be more effective in major surgeries longer than 3 hours, and stroke volume guideline or stroke volume guided fluid therapy reduces postoperative nausea and vomiting and antiemetic requirements in cases like gastrectomy patients. Another one that we're going to see more and more of, I think, with these goal-directed hemodynamic strategies is avoiding hypotension. So if we step back, a big practical message emerges here. A postoperative nausea and vomiting prevention plan begins long before we open the drawer to pull out an antiemetic. It starts with anesthetic choice, opioid plan, regional plan, reversal choice, hydration, and hemodynamic stability. This is all within the CRNA's wheelhouse. All right, so let's look at adult prophylaxis as it's written in the 5th consensus guidelines. And they push harder towards a minimum of 2 interventions. One of the clearest statements in the executive summary is guideline 3 in the document. Administer postoperative nausea and vomiting prophylaxis using 2 interventions in adults at any risk for post-op. That goes from 0 all the way to 4, right? That's a big deal. And the adult algorithm figure that actually is outlined in the actual document pushes it even further. Patients with a 1 to 2 risk factor should get 2 agents plus risk mitigation. So that's your anesthetic technique. Those with 3 or more risk factors should receive 3 to 4 agents plus maximize risk mitigation. And if you pull the document from online, it actually shows up on page 8 in the adult management algorithm. That is a major, major change, right? More aggressive techniques and our anesthetic plan. So it's a little bit more assertive than the older consensus guidelines, more conservative prophylactic approaches, if you will. Now, for CRNAs, this means the default approach for many adults should be a single prophylactic drug. That single dose of ondansetron for moderate risk patients is no longer the spirit of best practice. The direction now is multimodal, proactive, and more routine. Not reckless, not indiscriminate, but broader and more deliberate. And the rationale makes sense, right? Most adult surgical patients have at least one risk factor. So adherence to risk-based protocols is really inconsistent, and common antiemetics have favorable safety profiles at perioperative doses. And we all know that. So that's the new mindset.
Are you a resident or CRNA looking to transition into independent practice? Introducing the 1099 CRNA Institute, taught by Beyond the Mask host Jeremy Stanley and Sharon Pierce. This comprehensive educational series provides detailed guidance on business structure, legal and tax implications, and financial management, tailored specifically for 1099 CRNAs. Enroll now and earn valuable continuing education credits as you chart a new course in your rewarding career. Visit aana.com/1099 to learn more.
Single agent options. And so what does the guidelines actually sort of emphasize here? So let's go through some of the major antiemetic categories in the clinical practical way, if you will. So 5-HT3 receptor antagonists, that's your serotonins, right? So they still remain foundational at treating postoperative nausea and vomiting. The guideline actually notes that serotonin receptor antagonists generally have a stronger anti-vomiting than anti-nausea efficacy. And so some of those ondansetron, that still remains the staple. It's not on patent, so it's cheap. The recommended dose still is 4 milligrams IV slow injection or 16 milligrams orally disintegrating tablets 1 hour before induction. Now, the guideline notes that ondansetron monotherapy is more effective than dexamethasone for prophylaxis, and it has fewer side effects than compazine and droperidol, in some comparisons. Now, polanzatron, this one is a little bit more important and a newer emphasis for this drug. Now, polanzatron has a 40-hour half-life. Yes, 40-hour half-life, and it's more effective than a single dose of ondansetron for reducing 24-hour postoperative nausea and vomiting. It is also comparable to repeatedly redosing ondansetron over time. So, polanzatron is a drug that is especially interesting for the ambulatory surgery population, high-risk patients, and what we talked about a little bit earlier with PONV prevention. Granisetron and the other ones like romazatron and tropisatron, they're also discussed in the document with some evidence of improved control for late postoperative nausea and vomiting depending on that agent and the dose. They tend to not be the high hitters, if you will, but we do see them in practice in some of our locations. Dexamethasone. So that still remains one of the most effective agents. 4 to 8 milligrams is the typical recommendation. The guidelines actually note that it was among the 5 most effective single drugs for prevention of postoperative nausea and vomiting in a large network meta-analysis, and that 8 milligrams of dexamethasone may offer optimal antiemetic and analgesic benefit. More importantly, the guideline actually states that the single dose of up to 8 milligrams does not increase postoperative wound or systemic infections, including patients with diabetes, although transient hyperglycemia may occur in the diabetic population specifically. Now, that's very relevant in day-to-day anesthesia conversations because dexamethasone is sometimes withheld over concerns that are not supported by the current evidence in routine prophylactic doses. So just something to kind of put in your hat. 4 to 8 milligrams is safe, and basically no matter what the scenario is, diabetics, etc., surgical site infections and whatnot. Dopamine antagonists. Amisulpride is one of the more notable additions now in contemporary postoperative nausea and vomiting practice. The guideline actually supports 5 milligrams IV for prophylaxis and notes that 10 milligrams IV is a FDA recommended rescue dose. So 10 milligrams for rescue, 5 milligrams for prophylaxis. It also states that the dose up to 10 milligrams IV did not lead to any clinically significant QTc prolongation or extrapyramidal side effects. So that's really important. And that makes it especially attractive as a rescue agent after failed non-dopaminergic prophylaxis. All right, now the big one that everybody doesn't like to give anymore is droperidol, and that's recommended prophylactic dose at 0.625 milligrams IV. Ideally, near the end of surgery, the guideline reviews the long-standing FDA black box warning, which kind of spooked a lot of people back in the day, but it also notes that low-dose droperidol for PONV has, QT prolongation potential similar to that of ondansetron. So retrospective data did not show any increase in polymorphic ventricular tachycardia or death with low-dose use of droperidol. And that's helpful in the context of treating postoperative nausea and vomiting. Droperidol is highly effective and often underused because of that lingering fear in anesthesia providers' minds. Another one is haloperidol. 0.5 to under 2 milligrams IM or IV is still supported, and its efficacy is similar to that of 5-HT3 antagonists, but it does come with the greater risk of sedation. Metoclopramide, the guideline still says 10 milligrams is effective as monotherapy, but overall less effective than other antiemetics and with limited added value in combinations. So it's not recommended for prophylaxis unless other dopamine antagonists are unavailable. So that's really worth highlighting here, right? That's a shift. A lot of people are still using metoclopramide reflexively, and the guideline is essentially telling us it is not one of the stronger prophylactic choices. If, number one, you have a rescue or a prophylactic that fails, then you can consider it. Or if it's unfortunately you're limited as far as resources. Now, some of the newer agents like NK1 receptor antagonists. Now, this class does receive pretty strong report. Aprepitant has a half-life of 40 hours. It's more effective for preventing vomiting than it is comparative to nausea, and it appears to be more effective than 5-HT3 antagonists as monotherapy for prevention of PONV. It can also be effective as part of a multimodal regimen too. IV aprepitant now, the guideline notes that a PONV 32 milligram IV formulation as the only IV NK1 formulation with FDA indication for PONV prophylaxis. This is definitely one of the newer era changes compared to the oldest practice patterns, right? IV aprepitant as an option. Let's look at anticholinergics. The big one there is the transdermal scopolamine patches. It's still effective, still useful, particularly for longer coverage, and it can be applied the night before, on the day of surgery before going back. It can reduce the incidence of postoperative nausea and vomiting for approximately 24 hours, but it comes with its side effects, as we all know: dry mouth, dizziness, visual changes, and it may increase postoperative urinary retention in some urogynecologic patients. Other options, dexmedetomidine also decreases the risk of postoperative nausea and vomiting and postoperative pain, but it may also produce things, and we've all seen this if you push it specifically, bradycardia, which actually gets a reflex hypertension or hypertension, reflex bradycardia. And then you see hypotension and we see sedation, and that does delay the recovery room or the PACU discharge. Diphenhydramate, promethazine, ephedrine, these remain options in selected settings with side effect trade-offs that we all are aware of, particularly sedation from some of these agents. And yes, I did say ephedrine. And for those that have maybe haven't read the documents for a while, just remember that it is an option to treat. It's not a strong option, but it's there. Non-pharmacologic interventions, the guidelines also give attention to things like PC6 acupoint stimulation, which is considered comparable to pharmacologic prophylaxis in some settings. Aromatherapy approaches, isopropyl alcohol for rescue and limited evidence, lemon aromatherapy, as well as ginger for nausea more than vomiting itself. So that's another sign that the fifth consensus guideline mindset, not medication only, but multimodal in a broader sense. So let's look at combination therapy. Not all combination therapies are created equal, and the panel continues to recommend general multimodal prevention in adults, and it emphasizes that approach or appropriate combination therapy is more effective than monotherapy by itself. But here's where the fifth consensus guidelines feel more sophisticated than earlier versions. It's not just pick any two drugs from different classes. The document highlights evidence-based combinations that are supported by network meta-analyses, particularly for the prevention of 24-hour postoperative vomiting. And that's your NK1 antagonists plus a 5-HT3 antagonist. It incorporates NK1 antagonist plus dexamethasone. And then there's also a recommendation for 5-HT3s and dexamethasone. So NK1 antagonists, 5-HT3 antagonists, and dexamethasones are the combos that are the ones that the consensus document recommends. And that's very, very helpful, right? Because our antiemetic menu expands. We need more than just one mechanism. Having different mechanisms, we need to know which combinations actually has the stronger evidence. And the guidelines also note that evidence for combinations of 3 or more agents still remains somewhat limited, although there is some support for aprepitant added to ondansetron, dexamethasone, and propofol-tivas. Olanzapine added to the ondansetron and dexamethasone combination, as well as haloperidol added to the ondansetron dexamethasone combination. At the same time, The consensus group is very careful. They don't overstate the evidence. They explicitly say more research is required on adding third and fourth antiemetics in high-risk populations. So that balance is really important to understand. So, really the clinical takeaway is yes, go multimodal. Yes, use more than one intervention routinely, but also recognize that once you get to 3 or 4 agent prophylaxis, the evidence starts to become a little thinner and risk mitigation strategies now actually matter even more. So the adult algorithm, very practical for CRNA workflow. That guideline is one of the most useful visual summaries. So on page 8 of the actual guidelines or consensus document, they have this beautiful visual summary that's very, very helpful. They lay out things like management is assess risk, strategize, mitigate risk, prophylaxis, and rescue treatments. Those risk factors that are emphasized in the document is female sex, history of PONV and motion sickness, non-smokers, post-op opioids, younger age, and surgical type. The mitigate risk section reinforces opioid sparing, enhanced recovery pathways, local and regional anesthetics, Sugammadex for reversal, obviously, of rocuronium, hydration, and avoiding nitrous oxide, volatile anesthetics, and anticholinesterase agents where possible. The prophylactic section includes NK1 antagonists, 5-HT3 antagonists, dexmedetomidine, dopamine antagonists, propofol tivas, anticholinergics, antihistamines, and acupuncture. So the rescue principle is pretty clear in this document, and using different antiemetic classes than the prophylactic drugs is one important, very teachable thing that we need to take away, not only for us as providers, but for students in protocol development. So rescue, this is a big one. Rescue treatment, one of the most common clinical mistakes. Guideline acknowledges that rescue treatment is in an era where less published evidence than prophylaxis is out there. And this actually makes evidence-based rescue recommendations even harder. Still, one rule stands out really clearly in this document, and that is if prophylaxis fails, use a rescue drug from a different pharmacologic class. That seems pretty simple, but there are practices where this often slips. Patient gets ondansetron, feels nauseated. Then they get more ondansetron. The guideline specifically advises against routine reflexes, giving the same thing over and over. And I think Einstein had a quote there, if my memory serves me correct. If more than 6 hours is elapsed, then a second dose of a 5-HT3 antagonist or butyrolphenones may be considered if no alternatives are available. So that's prudent decision making. But clinicians, should avoid redosing long-acting antiemetics like apripitant, fosapripitant, pelanzatron in the PACU. And transdermal scopolamine is not useful as a rescue because of its slow onset, obviously. That's clinically really important. So patients that are antiemetic naive, the guideline supports ondansetron 4 to 8 milligrams, droperidol 1 to 1.25 milligrams, and notes that propofol 20 to 40 milligrams is effective for treating postoperative nausea and vomiting. Now, patients who fail on ondansetron prophylaxis, the guidelines actually make note. Other 5-HT3 antagonists do not offer much benefit. So consider promethazine 6.25 milligram or amisulpride 10 milligrams are effective rescue alternatives. That's a very practical update that's listed in this document. So for CRNAs, rescue planning should be a little bit more built around the anesthetic plan. What do I use prophylactically? If it fails, what class is next in my sort of basket of tricks, if you will? Do I have a rescue sequence in mind if this patient continues to fail interventions? That's much better than improvising under pressure when the patient's already symptomatic and retching, and it's just disturbing to actually watch, quite honestly, and insulting because, we all know our anesthetics are the greatest ever, but you get that one patient that slips through. Let's look at pediatric PONV, a stronger, more developed part of the fifth consensus guidelines. It is another important advancement in the fifth guideline, in the fifth consensus document, and it's expanded its attention on pediatric PONV. The guideline notes that in children, postoperative nausea and vomiting, postoperative vomiting are often treated as distinct concepts, right? Especially because younger children may not be able to reliably describe nausea, and it highlights two validated pediatric models, the VPOP score and the POVOC score. Now, in the document, that's on page 9 if you pull it up, and it shows pediatric risk factors such as age, history of PONV, motion sickness, surgery duration, multiple opioid doses, high-risk surgery, strabismus surgery, and family history. Now, the pediatric section also emphasizes, like adults, risk mitigation. Propofolativas, they reduce POV and PONV comparative to inhalation anesthetics with single-agent prophylaxis. Liberal fluid strategies may decrease POV and PONV. Early oral intake and PACU help in some settings, depending on the procedure type. And dexmedetomidine can be beneficial in certain selected pediatric contexts. So in terms of prophylactic pharmacology, the effectiveness and the safety of ondansetron and dexamethasone, those are well established in the pediatric population. The guideline states that a higher doses beyond 0.15 milligrams per kilo up to 4 milligrams maximal do not add any benefit. Let me say that again. The guideline states that higher doses of Decadron or dexamethasone, doses that are beyond 0.01 or 0.15 milligrams per kilo up to 4 milligrams maximum dosing does not add benefit. Now, combination therapy in children is also more effective than monotherapy. So ondansetron plus dexamethasone is a best studied combination. What is especially useful is that pediatric algorithm in this document is very practical. If the kid has no risk factors, they get one agent. If they have 1 to 2 risk factors, they get 2 agents. If they have 3 or more risk factors, 2 agents, and maximize risk mitigation, so your anesthetic plan, right? The nuances really do matter in this scenario. So things like modifying or minimizing nitrous oxide, considering TIVA or propofol infusions, local and regional anesthesia, early multimodal analgesia, considering sugammadex instead of anticholinesterase-based reversals. So changing up our regimen and our approach from the anesthetic technique is an imperative. So let's talk about implementation costs and enhanced recovery. Just briefly, I'd be remiss if I didn't talk about this. The guidelines do go into things like economic considerations, and it emphasizes patient safety, patient experience, quality of life, operational efficiency, direct and indirect patient costs. I'm not going to get into those details, but they all have a consequence, and that's at the system level. Now, if your facility wants faster discharge, better patient satisfaction, which we all do, less delays, less rescue interventions, fewer admissions or observation holds, then PONV prevention deserves a structural, intentional approach to managing these patients. So I'll kind of leave that with, I'm not going to get into multimodal and opioid sparing and ERAS and stuff, but it does have a role here. So what are some of let me just list sort of the bigger differences of the new fifth consensus guidelines comparative to the fourth. Number 1 is stronger movement towards liberal multimodal prophylaxis, right? We've talked about that. Clear recommendations for 2 interventions in adults at any risk, right? More robust emphasis on PDNV, right? Post-discharge nausea and vomiting. More discussion on newer agents and classes like amulosuppride, neurokinin, NK1 antagonists, those types of things. Greater emphasis is on evidence-based combinations, NK1s with 5-HT3s, NK1s with dexamethasone, and 5-HT3s with dexamethasone. More integration of risk mitigation strategies, so that's your TIVA, hydration, opioid sparing, sugammadex, regional, are all initial considerations, not secondary considerations, right? We're trying to preemptively, prophylactically reduce or eliminate PONV. A stronger pediatric framework. And finally, more attention to health equity and implementation is noted in this document. So what are some pearls we can take away from these new fifth consensus documents for managing PONV? 1, ondansetron is still useful, but it is not the whole plan. 2, dexamethasone remains one of the highest value prophylactic agents. Concerns around single dose infection risk are not supported in the evidence, and they are summarized in the document. So it's hooey. They do not cause infection risk at the doses we're giving. Number 3, polanzatron and apripotent deserve more attention in ambulatory as well as high-risk patient populations because they extend beyond the PACU window. So PDNV is sort of what you're treating in that realm. 4, metoclopramide is no longer a top-tier prophylactic choice compared to others. 5, low-dose troperidol remains effective, and the low-dose perioperative context is important in weighing against those safety fears that we saw with the black box warnings. 6, use a different class when you're rescuing. If that initial drug didn't work, you don't give more. You jump to a different class. And this should probably be one of the most consistently taught PACU principles, is not the same jump to a different class. 7, the anesthetic itself on postoperative nausea, vomiting intervention. We've talked about this. TIVAs, hydration, opioid sparing, Sugammadex, regional anesthetics are not now side notes. They are part of the risk mitigation strategy. And finally, 8, think about tonight, not just the next 30 minutes. That's the PDNV lesson. We want coverage for patient going home and not getting sick when they're at home. So we want something that's longer lasting. So that's the big picture of the fifth consensus guidelines for the management of postoperative nausea and vomiting. For me, the main message here is we should stop thinking about PONV prevention as a minor add-on at the end of the case. Instead, PONV prevention is part of the anesthetic design that we create for our patient. It starts with risk recognition. It continues to the anesthetic plan or the anesthetic technique. It includes multimodal prophylaxis. It requires smart rescue planning, and it extends all the way to post-discharge recovery. So for nurse anesthetists, this is not just relevant, it's central to our everyday practice because we are often the ones building the anesthetic from the ground up. That's deciding whether to run a TIVA, choosing opioid-sparing options, deciding on dexamethasone timing, choosing the reversal strategy, planning antiemetic combinations, and handing the patient off to or with a coherent plan if nausea breaks through. That's why these guidelines matter. They validate the idea that thoughtful anesthetic care improves not just physiology, but recovery quality. So with that, folks, thank you so much for listening today. I apologize, Lynn is not with me today. We tend to like to have a lot of fun, but I thought this was a nice, quick down and dirty to kind of review the new consensus guidelines that have come out. So folks, if you found this helpful, share it with a colleague, a student, or your department. Jump on over to the website, give us a like, thumbs up, preferably not a thumbs down. Make some comments. Is there something else that you would like to hear that's perhaps germane to your practice, and perhaps that might even be many CRNAs across the country. But please visit the website and share some of your comments with that. So until next time, I want to thank you for joining us here on Anesthesia Alchemy, Lynn and Gary Unplugged. And until next time, thank you for joining us and listening.